County Medical Society, its members, nor KCUS TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
It's October. It's Breast Cancer Awareness Month. 3 of us are wearing pink, 1 didn't. We'll get to that later. There is an awful lot to be thankful for. There's a lot of new research, new treatments, new screenings, and very specified treatments for individuals, and we love that. During this next hour, we have physicians answering your questions about all the updates happening in breast cancer. We're going to talk specifically about what's new in the world of breast cancer treatment. We're going to talk a little bit about implants, too. If you've been listening or watching the news throughout the day, you know that there's some news about that, too, so we're going to be very current event on that. As you know, this is a live program, so give us a call at 881-0013. We are also streaming live on Facebook, so if you have a tablet or a phone and not close to a television, you can always ask questions on Facebook, and then we also have somebody monitoring that, and we can get to your questions that way as well. This evening program is underwritten by Texas Oncology, the El Paso Cancer Treatment Center. We also want to thank the Texas Tech Paul L. Foster School of Medicine for providing our medical students. And as all of us know on El Paso streets, we think one of the students is stuck in traffic. With us tonight, we have Nicholas Martinez, and Alyssa Greenwood Francis is going to be joining him when she gets through the 25 million cycles of lights to get to where our station is. I want to say thank you so much to the El Paso County Medical Society, who supports and has been underwriting the show for over 22 years. Good evening, I'm Catherine Berg, and you're watching the El Paso Physician. I know that as a host, I'm not supposed to say that I have favorite doctors, but I kind of do, and I've got all 3 of them in front of me. It's kind of nice to see you guys. We have Dr. Anu Gupta, who is a radiation oncologist with us this evening. We have Dr. Mark Landeros, who is a surgical oncology, specializing in oncology surgeries, but he's also a general surgeon. And then we have Dr. Regine Rivera, and she's a grandma, and she's also an oncologist. And she's trying to figure out how to get to Austin tomorrow with our weather. It's so nice to have the 3 of you with us every single time. And we talk about October Breast Cancer Month, and every time it's so different. There's a lot of information going on right now with recall, so we will talk about that. But before I do, I'd like to introduce the 3 of you to the audience with your different specialties within the world of cancer and breast cancer. So, Dr. Gupta, as a radiation oncologist, what does that mean in the world of cancer?
As a radiation oncologist, I'm a specialist who treats cancer and non-cancerous conditions with ionizing radiation and radionuclides. So I'm part of the team of surgical oncology, medical oncology, that adds to the management of any patient with cancer.
And I always look at you, because I don't know if you said the word one time, but you get to work with the gadgets.
I do.
You do.
I get to work with the high-tech stuff.
All the high-tech stuff, yeah. And that's always great, because you're always on the forefront of what's coming above, what can we afford, what can we get in this town, so we appreciate that very much. Dr. Landeros, so you are a general surgeon, but you specialize often in oncology surgery. And if you can explain to the audience, how often is that breast cancer surgery?
Well, in my practice, I would say about 70%
okay.
is related to breast. Of those, a good percentage is breast cancer.
Okay.
I'm often the first line of treatment within this multidisciplinary team. And if Dr. Gupta said she is the person working with high tech, I'm the one working with low tech. I'm the one with the chisel and the hammer. Actually, I'm the one to remove the actual tumor. I like to think myself a little bit more than just a technician, but that's what we do.
Well, I think sort of like she's electricity, you are mechanical, and you're chemical, the way I see it. So in my head, that's how I think about cancer treatments, because you're the chemo doc, so to speak. So you are a medical oncologist. What does that mean to the folks at home?
Well, a lot of people don't realize it, but most medical subspecialties go through internal medicine first. So we're internal medicine docs that specialize in the treatment and care both initially and after with breast cancer and all the cancers that we have. Tonight, of course, breast cancer.
Mm-hmm.
Yes, we do chemotherapy, but I often tell people many medical oncologists want to find reasons not to do the cytotoxic drugs that people think about chemotherapy. I mean, there are other alternatives. And that's our job, is to look at all the alternatives, balance risk versus benefit, and then prescribe what we think is the best therapy.
And I love that there is a team of, even though you all are treating cancer, but the disciplines are very, like you said, interconnected. It's like a nice pretzel if everything works out beautifully. On that note, I'd like to start out, because I know it's going to be hit later and people are going to ask, and it's the most confusing question of the evening, is screenings. So Dr. Gupta, you and I met 25 years ago, and screenings were this way, and then 2 years later they changed, and then 2 years later they changed again. And I know that there are so many recommendations from so many places, so I'd just like you to start off, if somebody is asking you, what is the recommendation for screening? And you don't have to name who. If you have it in the back of your head and you've got it memorized, great. If not, what would you tell a woman who's 20, let's say?
For a 20-year-old, it depends on risk factors. I would not start screening at 20 for an average risk woman. For an average risk woman, I think almost everyone agrees screening probably should start around age 40.
Okay.
And societies differ in their recommendation, whether it should be 40, 45, but roughly 40 is a good time to start.
And when you're saying screening in that sense, you mean mammography, correct?
Correct.
Okay.
For screening, currently, the only tool that we have for average risk women, again, is mammography.
Okay.
Which could be digital mammography, which is the mammography that's used at this point, or it could be 3D tomosynthesis. So
Okay.
that could be used for screening too.
Okay.
But at age 20, I would only start screening very high-risk women.
Okay.
In what I do, I usually will screen at age 20 if I've treated a youngster, say 10 years old, 12 years old, for Hodgkin's lymphoma, to the area of the chest or face with radiation therapy. That child was cured, but has a higher risk of breast cancer. You start screening 8 years after finishing treatment.
8 years after finishing treatment.
Yes.
Okay.
So that
this
would
is
be
good because
one.
it kind of brings in the whole risk factor.
Yeah. So
Okay.
that is the one that I would screen at age 20.
Okay.
I know we've all seen about 5% of women will have breast cancer before age 35. So it's rare to see it, but we've all seen women in the 20s. So my message again is never ignore a lump.
Exactly.
If you feel uncomfortable with your breast or feel a lump, get professional attention. And then a mammogram ultrasound could be ordered.
So in and I know this is breast cancer, but in a yearly exam, and that used to be yearly, but maybe it's not, when a female goes in for her exam, is that recommended like once every 3 years now? Because I always think to myself, that is also the exam when a doctor just feels for any abnormalities in the breast. And is that still the going?
It still is the case starting age 40.
Oh, it's still age 40?
It's still age 40.
Okay.
That once a year you get a clinical exam done. It's the breast self-exam that was taken away because it did not show that improved finding of breast cancer or survival.
Okay.
But I don't think there's anything wrong in doing a breast self-exam either.
Right.
So going back to the screening guideline, between age 40 to 44, a woman has an opportunity to get a mammogram, but the screening guideline for American Cancer Society, for example, does not call for it as you should do it.
Right.
It should be a discussion,
Okay.
a shared decision between that patient's provider and herself.
And I know that Dr. Rivera will talk about genetic testing too in a little bit, and that how that gets not complex, but it gets to be different ways. And you were talking about
Exactly.
risk factors.
And for
there's different risk models that actually even the radiologists will do. And if you have a certain risk model, let's say that gives you a greater than 20% lifetime risk, you're eligible to receive MRIs. But then again, we're not dealing with the average population. We're dealing with high risk. And those people may get MRIs on a year. NCCN guidelines for high risk still include breast self-examination, but I completely agree with what Dr. Gupta says. Truthfully, I think doing breast self-examination just makes you breast aware.
Yeah, I agree
More
with that.
than anything.
right.
Yeah.
Right.
actually, the American College of Surgeons still includes it.
recommends it.
They still
That's
recommend
right.
it.
Very good.
Now, everyone agrees that between age 45 and 54, a woman should get annual mammograms. That one, I think
Without
everyone agrees,
question.
without question. And that woman should also get a yearly exam
Okay.
by a clinician. After age 55, you can go for a mammogram every other year. I think most societies agree to that
Again,
now.
without
Without
risk factors.
anything prior to.
Exactly.
Okay.
And a woman should continue having mammograms as long as she's healthy, that you think this woman's going to live another 10 years, irrespective of age, have a mammogram.
And if you're a very sprite 90-year-old, go have your
Have a-
mammogram.
We have treated 90-year-olds that have come up with breast cancer.
So with pap smears, and again, I know this is breast, but with pap smears, what is that? Is that every 3 years, starting at a certain age?
After age 60, now the recommendation is no pap smears.
After
If
age
you've
60?
always
no.
had
Okay.
normal pap smears. Now
Gotcha.
we're talking about not a woman who's had an atypical pap smear at any time, doesn't apply to her.
Okay.
But lifelong, if you've had normal pap smears, then after age 60, you don't need to get one,
Okay.
which was a change.
Right.
Yeah.
Right. Dr. Lenderos, let's say now somebody has had a mammogram and there is something suspicious, and we come to you as a surgeon, yes, but then also as the person who does the biopsy. And I'd love for you to explain what you're doing during the biopsy, because I think sometimes the information is just scary if you don't know. And the more information you know, what's happening, you know, it's more like, okay, let's get this biopsy done so we know for sure. How is a biopsy performed? And I know there's different types.
Well, you have
So-
to remember, a mammogram is an X-ray, right? There's an X-ray machine that emits a beam, passes through the tissue, the breast, and gets picked up on a plate afterwards. So it'll issue. The colors. It's a variation of grays from black to white.
Right.
And most of the time, something suspicious on a mammogram necessarily mean it's cancer, but it means that needs to be worked up further. And by work up further, you need maybe another method of imaging, and that could be, a lot of times mammogram is accompanied with an ultrasound. And the ultrasound is sound waves and allow you to tell those shadows that you've seen on mammogram, whether it's a solid mass or has fluid in it, maybe a benign cyst, something that doesn't require a biopsy. Once both methods of study, the mammogram and the ultrasound are done,
And can you
and
tell, I'm
still-
interrupting you, I know, but can you tell from an ultrasound whether it's a mass or if there's fluid in there?
Yes.
Or is, oh, you can?
Yes,
Okay.
you can.
Okay.
And a lot of times you can differentiate between benign and malignant
Through the ultrasound?
through the ultrasound, yes.
Huh. Okay, how long have I been doing this? I did not realize that. That's why I thought, okay, this is where the biopsy comes in. Explain that. Is that new or has that always been
No,
the case?
it's actually been
Okay.
for many years.
Okay.
Depending on how the mass looks, or let's call it a lesion.
Okay.
How the lesion looks on ultrasound, you can tell whether it's well circumscribed. It has normally fluid allows the sound waves to penetrate and be enhanced after the lesion. That's usually an indication of benignity, something that you wouldn't biopsy.
Okay.
If there's any irregularity, let's say the edge is very abnormal, there's a huge shadow behind it, meaning that ultrasound waves don't penetrate this thing.
Right.
That means that the tissue is very, very dense.
Right.
And then maybe that's considered suspicious, and that
Okay.
triggers a biopsy.
Gotcha.
So the patient comes to my office. Usually they come with both studies. Very unlikely that only a mammogram is done. And with the combination of both studies, the radiologist issues it's a, sort of a grade. It's called the BI-RADS system. And the BI-RADS can go from BI-RADS 0, needs more imaging method, to BI-RADS 1 is completely negative.
Okay.
BI-RADS 2 is something benign, you don't need a biopsy. BI-RADS 3, it's called probably benign. That's actually, most of my office visits are BI-RADS 3.
Gotcha.
And
Probably.
probably
I like
benign
the word
means,
probably.
means that most of them, or 95% of them are going to be benign.
Good.
Only between 2 and 5% merit a biopsy,
Okay.
or will be malignant in the future. So those need a follow-up essentially. Sometimes a biopsy, depending on how they look. So the patient comes to me with a lesion. Sometimes they're not. A lot of times nowadays they're not palpable. You don't feel them because the screening methods pick them up when they're small. So if I can see them in the ultrasound, and your ultrasound usually guides the biopsy. Now there's two different types of lesions that you can biopsy. One, on the mammogram only, calcifications. These are
Right.
deposits of calcium within the breast.
Mm-hmm.
You don't feel them. There's no mass, a lot of times no mass associated with them. And the only method of seeing them is through the mammogram.
Mm-hmm.
So you would go for what's called a stereotactic needle biopsy.
So this is me, and
Yeah.
I don't mind telling the audience because sometimes it's just nice to know that there's a human that had that. So that was me, and on the mammogram, it looked like somebody took a salt shaker,
Correct.
and then there were all these dots. I mean, literally like 50 little dots right there, and they're like, "Yep, these are calcifications." I never knew about that until it occurred with me, and I was 38, I think, so it was
Right.
still kind of young. So stereotactic biopsy, again at that time, and I'd already been doing the show a little bit. I thought, what in the world is that? It was fascinating to me because I didn't know that's something you could do. So I'm going to have you continue, just because I think everybody knows how a normal biopsy is done, but a stereotactic biopsy, what is the goal there?
Well, the goal is to retrieve the area of calcifications the best you can.
Mm-hmm.
Some calcifications are widespread, they're in a wider area, and it's difficult to remove all.
Mm-hmm.
Normally, the stereotactic needle biopsy takes about a cubic centimeter of tissue. So, and a lot of times the lesion is small enough where they can, if not all of them, a large majority of the calcifications that are seen. Now, calcifications in the mammogram, they are suspicious when they become pleomorphic, meaning different shapes, clustered. That's mainly one of the issues. When there's a little architectural distortion around them, those are things that the radiologist looks at to call them suspicious
Okay.
and ask for a biopsy.
Okay.
So it's done on a mammography table. A lot of times the patient's laying on their tummy. The
Right.
breast is sticking out through one of the holes in the table. Underneath there's a mammogram machine that's connected to a computer. The computer dictates the coordinates where this needle should be fired and the radiologist places the needle close to where it's supposed to be according to those coordinates, injects a little bit of local anesthesia, puts the needle where it's supposed to go, and it fires. The
was
radiologist fires this
fascinating.
thing.
Yeah. No, I remember that going on, and luckily, the majority of my calcifications were taken out by the biopsy because it was not necessarily technically clustered, but they were all relatively in a place where they didn't have to move me around too many times.
And
Unclamp
we just
like
have to
2 or 3
remember
times.
that not all calcifications are suspicious.
Right.
So people run, hey, I have calcifications, I want this taken care of.
Right.
And a lot of times they're loose, or they may be widespread but loose in the breast, and they don't represent any harm at all. So it's just a matter of judging and classifying according to the BI-RAD system where they merit a biopsy or not.
See, what's beautiful already about this discussion, in the audience, there are some people that are afraid to go get the mammogram. So even if there may be, you said 1, 2, 3, that often, if it's suspicious, often, if it's even a 3, it's a probable benign. So it's worth going because if it's caught early, it's fantastic. I'm not going to switch gears, but I want to kind of start the discussion because I always look at you as gene lady, genetics.
That's for December.
And that's why you have a granddaughter or grandson.
Grandson.
Grandson, oh my goodness. So in the world of genetic testing, and I know we've talked about this almost every show for the last decade or so, very separate from the idea of screenings. You don't want to just go out and get genetic testing for an average risk type person. Take that any way you would like when you talk to patients or talk to, when you're having seminars or whatever. How is genetic testing done, and why and with whom is genetic testing done in the world of, I guess, female cancer? It used to kind of just be breast, but it's really kind of gotten into females and more.
There's guidelines, and most of the guidelines, which we're going to talk about tonight, we'll talk about breast.
Okay.
And these guidelines, believe it or not, are changed almost every 6 to 12 months. So the latest guidelines are talking about not only are we looking at younger women with breast cancer, usually under the age of 45, but I consider under the age of 50 also, especially if there's other extenuating circumstances, bilateral breast cancer. Families that have ovarian, male breast cancer, these are all disturbing. Multiple cases of breast cancer, in particular where you start seeing breast cancer under the age of 50. So you kind of put all that together, and those are the ones that you want to test. Have I seen a positive genetic test where there's not much of a family history? Sure. Why? There are only men in the family. Uncles, brothers,
right.
cousins, no women. Maybe they don't know about their family. You know, we have a military base here, and these individuals may have lost communication with their family for periods of time. So there's reasons why you can have a positive test with a negative family history.
Right.
Then a personal. A woman comes in, she's had breast cancer, clearly under the age of 50, certainly 45, but certain types of breast cancer, like the triple negative breast cancer, under 60. All women should be tested for that. So I think it's important to recognize that the definition of who should get genetic testing is expanding. We now test all ovarians, all
Okay, that's
ovarians.
good.
We test
Okay.
all primary peritoneal cancers. We test all male breast cancer. And when you look at the number, that's huge. Now, I didn't mention another thing that's coming in is that many patients with certainly BRCA mutations will have a family history of prostate cancer, usually in younger men, biologically aggressive, and that also enters into the testing. So,
And next year again, this is going to be a very updated discussion. We talked about breast cancer last month. It was September, prostate cancer month. So there was a lot going on there that I wasn't aware of either, just within the last year of what's now being matched and what's where in the world of the testing. So when we, how can I ask this question? So what is the genetic testing looking for? Mutations, certain types of genes within the DNA, what at least today is able to be seen by genetic testing, and what are we still waiting to be able to see?
well, you know, you have defined a certain group of genes that are related to breast cancer.
Okay.
But we're in the infancy in genetic testing, and there's going to be crossover. We know that there are certain colon genes that may have an increase in breast cancer. A little unnerving. Is it true? We don't know yet. So what we try to do is identify those genes that we actually can tell a patient about something. You know, if I discover a mutation in a patient and I say to them, I don't know what this means, have I benefited them? No. So I think it's important to recognize you need to be careful. You don't want to order too much because you may not be able to give them an adequate explanation.
Right.
So most genetic companies will have what we call panels. Panels that try to address specifically the cancers within that family. Sometimes you just wind up ordering a larger panel that will cover prostate, perhaps melanoma, breast, colon, but you try to be a little bit more specific if you can. And then I also keep in mind women that have had BRCA testing, let's say 5-6 years ago, it may not be the appropriate test. They were not looking at the other breast genes. And so many women now we're having to go back and test.
And do retesting.
And actually are finding things. So
So
updates.
would it be a good idea, and I'm just thinking about the world of recurrence, and is it still with breast cancer, 5 years clear? It seems that things are going to be fine. Is that still
No.
that? No. Okay.
No.
Everything's changing. So what is the recommendation? I know that, go ahead, Dr. Landauros, you know where I'm
Maybe
going with this.
Certain type of cancers, probably, like the triple negatives, for example.
Okay.
They usually recur in the first few years.
Okay.
And if those people, you can say, okay, it's been 5 years, they didn't recur early, then it may not come. We're not talking about, never talk about cure.
Right,
But,
exactly.
but the chance of recurrence is very low.
Okay.
But the estrogen and progesterone positive tumors, these are tumor markers that we'll look for in each tumor individually. They may recur 10, 15
anytime,
years
so just
later.
that is
so
always to
they
be checked
they
again.
need a continuous surveillance. It's very important,
Okay.
imperative that they continue seeing their physicians and having screening mammogram and
it's-
exams.
Right.
Mhm.
I like the surveillance word. I'm going to bring that up a couple of times. So I'd like to bring up, because I know the show goes so fast, with women, because this show particularly is labeled breast cancer. So anyone who's had breast cancer is probably watching if they know it's on, because, hey, I had that. So the last several days, or even just today, I don't remember, was it today or yesterday, when there are so many women who have had breast cancer, who have had reconstruction with implants. And Dr. Landeros, you said, let's definitely talk about that or address that this evening. So on that note, I know very little compared to what you know. What is it that is, because it said all breast implants, or all breast implants, if I understood it right. And again, I was watching TV, and when you're halfway watching. So what is the situation right now?
Well, let me put it into context a little
bit.
Remember that in the United States, between 300,000 and 400,000 patients get implants. Most of them are cosmetic, but a good percentage are reconstructive.
Okay.
So, since 2011, the FDA has been monitoring the appearance of a specific type of lymphoma associated with breast implants. First case was, I guess, the ears of the FDA perked up at that 2011. They've been following ever since. All the companies, reports from physicians and from the actual manufacturing companies. And to date, this special type of lymphoma called, it actually starts with breast implant associated anaplastic lymphoma.
Oh my goodness.
It has
so
a
it's
name
actually
for
labeled as such.
It's labeled.
Okay.
Now, having said that, please remember that the number of cases detected to date in the United States has been 573.
Oh, so that's,
So
in the
it's very
grander
low.
scheme of things, it's very low.
So the risk
right.
is maybe 1 in 2,200.
Okay.
The 0.01% chance of that. So even if the worst case scenario, it's a very low incidence. Now, the company that's been associated with this more produces these implants with texture on the surface in order to provide maybe a better fit, better associated with the surrounding tissue. And those textured implants are the ones that mostly are associated. Out of the 573 cases, maybe 481 were associated with these textured implants.
So it's textured.
And specifically,
okay.
and there's a company specifically that the FDA is calling upon. It's called Allergan. And the specific models, and then natural models, including the tissue expanders.
Okay.
So all those had been recalled. And by recalled, I don't mean if you have implants of this type, go and have them removed, but from the shelves, meaning no longer used. The benefit of these textured implants, it was thought to be a few years ago great, tissue assimilation and cosmetics and all that. But so I think the benefits, the risks outweigh the benefits by far. So those are going to be phased out. All the patient right now needs to know when they're confronting the issue about reconstruction or cosmetic surgery is that they need to speak to their plastic surgeon and ask them, okay, this has been what's said in the media. What are my risks about having? Up to a year ago, the other implants were not associated. The smooth implants were not associated with it. I think there's been 1 or 2 cases now reported in the last year. So that's even a lesser.
1 or 2 cases. So that's enough to throw that.
Right.
And that's what bothers me about media. And we'll talk about websites in a minute too. One out there, and then all of a sudden it's all over the world, and it's not half as bad as one might think. Media is great, and then sometimes it's scary. So on that note,
take-home message is, if you have the implants already, if those are the ones that have been recalled, and you have them in, visit your physician. Okay. You need, just like a regular exam, breast examinations. If you have pain, if you have a mass, or there's fluid surrounding the implant, immediately go see your physician. Okay. There's different findings that a physician may be able to look at, and then trigger a removal of fluid to test or a biopsy, and then find out. Not all of it, obviously the great majority of these implants are not going to cause cancer. Right.
And I like that you said that too, some of the symptoms, and I saw the list of the symptoms too. It includes fatigue, which who's not tired?
Yes.
So it's hard, but if you do look these things up, and love to have all three of you jump in. So when the media hits, then it's like, oh, I'm going to Google that really quick, and it just becomes Dr. Google. So the two websites that I always refer to during this particular show is the American Cancer Society website, which is cancer.org, and then the National Cancer Institute. Is that right? And I think, I don't have that. Actually, you can Google National Cancer Institute, but often if it's a .org, it is more credible in the world than a .com. .coms are usually advertising, money-making type of a thing. So .org is kind of what you're looking for if you're looking for some kind of, and that's with any show that we do here on the air, whatever the situation is. The .orgs might be, it's not the only way to screen, but that might be helpful. Any place that you all can point people?
Well, actually, we were talking before the conference, and that one of the things that I was not aware of that you said was that the risk may continue even after you remove the implants. So
Because of residual material?
Well, what is the cause of this? That's the question. How is this stimulating the immune system or suppressing the immune system that you develop these lymphomas? And that's what Dr. Landeros was making the comment, that you may still be at risk, very small, even after you remove the implants. That's stressful.
Yes, it is stressful.
Yeah.
Because you are wondering, and it's interesting too, because it's lymphoma. It's not a form of breast cancer.
No.
So that in and of itself, I remember when I was listening, again, I was listening with half an ear because I was on my way out the door, because automatically in your head you're thinking, okay, if it's an implant, somehow it's associated with another breast cancer or, but it's a lymphoma. And that is and maybe as the hematologist oncologist, can you explain to the audience what lymphoma is? Just really quickly, what type of cancer a lymphoma type of a cancer is versus what we're talking about.
Well, these are cancers that originate from lymphocytes, and usually they're divided into T-cell lymphocyte lymphomas or B-cell. Now, there are some that are so poorly differentiated that they have no T or B-cell, but that's really what we're talking about. They can be fairly indolent in some cases, or they can be highly aggressive. And what they're talking about there is a relatively aggressive lymphoma.
Okay, nicely said. I want to talk a little bit about MRIs, question from the audience too, because we're looking at mammograms, we talked a little bit about sonograms, but when should a woman get an MRI of the breast? Does something need to be suspicious in a mammogram or in a sonogram to get an MRI? And I'm throwing that out to anyone who wants to take it. Dr. Gupta?
Usually we order MRIs if the woman is at high risk for breast cancer.
Okay.
So if her lifetime risk is over 15%, then MRI is recommended. So as Regine was saying, in a woman who has BRCA1 or 2 mutation and you want to screen, you alternate the MRI and the mammogram. You still do mammogram, but you alternate it with an MRI because an MRI becomes much more sensitive. It's less specific, but it is more sensitive in picking up breast cancer.
Okay.
So that would be one instance where you'd get it. If there's a personal history of breast cancer and there's a concern on a mammogram, you'll get an MRI to sort it out between the mammogram and the ultrasound itself. I will order MRIs in my Hodgkin's and non-Hodgkin lymphoma patients against very young patients who've been treated with radiation therapy to the chest, and they are considered very high risk for breast cancer. And so in them, it's always alternating MRI and mammograms. Now, having said that, MRI is done with contrast. And there are concerns about using this contrast regularly. Right. Because it can get deposited in the skin, kidney, brain. And so that concern, we've only come to know of it in the last few years. I would never think of it when I ordered it, and now when I'm ordering it on the younger ones, when I follow the Hodgkin's patients.
Right. So it's what's left over of the contrast.
It's repeated use of contrast
okay.
That can get deposited in the brain.
Okay.
Or in the skin, or be nephrotoxic, meaning toxicity to the kidney.
Right.
And so I've actually gone every other year now because of that reason.
Okay.
Because these are young women, and you're going to be ordering them for a long time unless something else comes up. So that becomes a really big concern to me now.
Exactly. Dr. Landeros?
An MRI is not a screening tool. I think you mentioned it very
Yeah.
well. You have to pick and choose your modality. In this case, you may choose it to differentiate something benign or malignant that you don't know on mammogram and ultrasound. You don't have enough information about that lesion. And patients with very dense breasts. Even if a 70-year-old comes to me with a higher, maybe a 15 or 16% risk of breast carcinoma, and on mammogram their breast looks like completely transparent, I'm not ordering an MRI. I can see it very well in a mammogram.
I see. Okay.
But in somebody 40 years old,
right.
that the breast is completely dense and you can't see it very well, those are the patients that I'm a bit worried about. So
Okay.
I think we use it in very selected cases. We get a kickback from, not a kickback, but a pushback from the insurance companies.
Right.
Most of the time, because with good reason, we shouldn't
is
be
this necessary?
ordering all the time the MRI.
So explain to me again, 15% risk, 16%, 17% risk. That includes what? What do you see in your tablet of, okay, risk? So we're looking at maybe genetic testing of an ancestor or someone, a descendant.
No, it can be
could be
just
age,
a
it could
family
be-
history, pedigree.
Okay.
Is what you're looking at, and they actually have. I mean, when we do our pedigree, we actually have a way of calculating 4 or 5 different ways, and some of them probably overestimate, some of
Okay.
them underestimate. We use 20% for a couple, but I think ultimately it comes down to what's your personal and what's your family history. And current NCCN guidelines for a BRCA patient that has decided to continue her breast and not have breast removal are to alternate MRIs and mammograms. And yet, I tell them that is current recommendations. These things change.
Right.
And I am concerned what would happen if she does this for 20 years. What about this gadolinium accumulation? The radiologists in Europe and the United States say, we think it's safe. We think it's safe.
Right.
We just brought up about implants. How do we know what we're going to find, in 10 years? So I always tell people, stay tuned. The problem is imaging the breast. Tomosynthesis, it's new. The newer machines have a much lower dose of radiation. Can we do mammograms and ultrasounds? Well, that's another, but you've got to have a good tech that knows how to do it. It's not very helpful in very large breasts. So what's the ideal mechanism to screen for breast cancer? And
Great
I'm not sure.
question.
And the thing is, all of them, MRIs, I have seen an MRI that did not pick up a breast cancer. I have seen an ultrasound that didn't pick up a breast cancer. We've all seen mammograms. So really, all three complement each other. So what are you going to do, all three?
Yeah, that's the great question.
Yeah.
And when I found my calcifications, again, I was and I just had not a lump, but just self-examination at that time was something I just done, and because I've just always done that. And it was more of a dimple. There was just a little bit of a dimple there, and I thought, well, I'm just going to go check this out. But yeah, that's not something a sonogram would have found. The calcifications, I understand, are only found with a mammogram. And at the time, it's like, well, you're young, you have very dense breasts, we should probably do a sonogram. And they said, well, do a mammogram first because your insurance will cover it. And that's why I didn't have the sonogram. So yeah, it's just interesting to me how it's different all the time. I do want to get to treatment, because talk about things that are different. So I feel like in the old days, the form of treatment was surgery first, chemotherapy, then radiation, but it's different depending on what's going on. So now I feel like, and I don't know if it's right or not, I feel like I hear, well, we're going to do chemo first, try to shrink the tumor if it's a mass, then have surgery because it's maybe has a better margins you can get, et cetera, and then radiation. Sometimes radiation is first. I know there's 10 million types of breast cancers. How does one, Dr. Landeros, I'm going to have you just take it first, and feel free to add from there.
Okay, first of all, every
Yes.
cancer is different.
Yeah, exactly.
So patients, when they have a diagnosis, they can get recommendations from family members or friends,
gosh.
and this is what I had first.
Dr. Google again.
No,
Right.
everything has to do with the size of the tumor, the type of the tumor, whether lymph nodes are involved or not, and a lot of times the age of the patient. So in very particular breast cancers, for example, we mentioned in past shows the triple negatives,
Right.
which means estrogen, progesterone receptor negative, and HER2 negative. Those are very aggressive tumors, and they do very well with chemotherapy. They almost, in about maybe more than 60–70% of cases, you can see complete, and not only clinical response, but complete pathological response, meaning
So the
that
tumor completely disappears under those cases.
Yes. So I think nowadays we have to get all the information first. Your diagnosis is done by the biopsy, yes, whether it's cancer or not a cancer. And in 7 days, usually a week after, you get the prognostic indicators, the estrogen, progesterone, and that you determine with that all that information, putting the clinical picture of the patient together, then you can determine who goes first to chemotherapy and who has surgery first.
See, the molecular
Gupta?
markers have really changed the management in the last almost a decade now.
Yeah.
And
I think
repeat again which markers? I didn't.
Molecular markers.
Molecular
mean
markers,
The
gotcha.
estrogen
Right.
receptor, progesterone receptor, the HER2 new. That really has changed the understanding of how we should treat, which cancers will respond better to chemotherapy, and also it has changed the type of surgery Dr. Landeros will do. And in radiation oncology case, I have to think a lot harder now. Which are the cases that will benefit from treating only the breast? Where do I need to treat the lymph nodes also? Does the clinical stage matter? Does the stage after chemotherapy matter in recommending radiation treatment? So it's the molecular markers and understanding of pathology, what type of cancer it is. That's what's changed the management.
Gotcha.
And Dr. Rivera will tell us that if it is a HER2 positive cancer, node is involved in the axilla.
Okay.
That patient is going to get chemotherapy first.
For sure.
Yeah.
Okay.
The triple negative that Dr. Landeros was mentioning is going to get chemotherapy first.
Okay.
Then comes surgery, and then comes radiation therapy.
Okay. Dr.
Just-
Landeros?
Just as a corollary of this, there was a study from MD Anderson that's started accrual, I think, last year. And this is patients who have triple negative cancer, up to 4 centimeters in size.
It's pretty
They're-
big.
Yes.
Okay.
They're
Yes.
treating with chemotherapy
Okay.
up front. And if they have an excellent clinical and by biopsy of the area of a lesion, they determine there's complete pathological response. These patients may not go. They're trying to
Avoid surgery.
Avoid
Right.
surgery.
So
And
those are just chemotherapy,
Followed by
Everything's
radiation
gone.
therapy.
followed by radiation
Yes.
therapy.
And
Avoid
then
I
just-
see.
surgery.
Okay.
and then clinical
Okay.
follow-up without
Okay.
surgery.
Okay. And so in that, let's say in that case, how often at that point would the patient go back and just want to make sure I'm going to do a mammogram every 6 months? I'm going to, because I feel like chemotherapy, it's gone. I guess recurrence is always my question. So in that situation, gone by chemotherapy, no surgery, radiation treated too, so zaps that area as well. For futuristically, this particular patient that we're speaking about,
I think in the clinical trial that Dr. Landeros is mentioning, the follow-up mammography is still once a year.
still once a
It is,
year.
yes.
Okay, so
It
not-
is right after chemo finishes, the biopsies are done, and you have to have a complete pathologic response and radiographic response.
Okay.
Both have to happen before
Okay.
the patient is randomized to radiation or surgery.
See, in my head, I hear the word aggressive. And so I think, well, if it's going to come back, how fast is that going to happen? And that it's just a question to throw out into the
Over
universe,
triple
which
negatives,
is
they're aggressive. And
Yeah.
They're
they
aggressive.
will come back within 1-2 years. So you should be able to judge that.
okay.
We're not doing mammography much more frequent than that, unless there's a clinical suspicion,
Sure.
of course.
Right.
Then you're going to do it. If you're feeling something that is out of the ordinary that you think, then
But ultrasound is if you see it in an ultrasound and you
Okay.
follow these as they progress through chemotherapy, how they shrink, and lesions who at least, and they consider a very good response, lesions they start at 4, for example, and now they're less than 2 centimeters in size, they still consider that, if the biopsy is negative, as a complete pathological response. So it's very early to tell
Right,
now
right.
how often should a patient in that protocol should be seen, or should be examined? What methods of imaging will we use? But it's fascinating to think that I probably go fishing and not operate anymore.
You know,
Right.
we are trying to de-escalate treatment.
Right.
Right?
Yeah, which is a
And
beautiful
which
thing.
is a beautiful thing.
Yeah,
Same
absolutely.
thing, patients who get neoadjuvant chemo. There is a trial running where Dr. Landeros will do a sentinel node at the time of surgery. And after that, that patient may have either just radiation therapy or an axillary node dissection. The trial is trying to study, can you avoid the node dissection completely and just do radiation therapy and have the
Nice.
same exact survival and control of disease?
Right.
Because axillary node dissection has a issue with lymphedema, right? And radiotherapy can also create lymphedema, but
Right.
in a lesser number of patients. So we're trying to de-escalate, and that's why he's saying he's going to go fishing. I don't think so.
It's going to go fishing.
Yeah.
We have a whopping 11 minutes left. On that note, again, I know there's so much to cover, but I want to stop this for a minute and just talk to the three of you and see what you might want to get across this evening that either we haven't touched base on or that you'd like to cover a little bit more. And Dr. Rivera, I'm going to start with you. That way you can leave early and go to Austin.
No, not till tomorrow morning if I get out. You know, I think the biggest emphasis in breast cancer are to look at the molecular subtypes. You know, in general, we divide breast cancer, and it depends upon what you're asking, but in general, we have the triple negatives, and we've already defined them as ER, PR, HER2 negative. You have the ER positives that are probably 70 to 75% of all breast cancers, and that's divided into what we call a luminal A, luminal B, meaning low grade, high grade. And these luminal Bs are bad tumors, so they probably need chemotherapy. And then you have a third group that are the HER2 positive that are also divided into two groups. The HER2 positive, but the hormone receptor negatives. These are very much like your triple negatives. These are bad cancers, but potentially curable even in advanced settings. And then you have your HER2 positive and ER, PR positives. And so we're looking at the different subgroups, and they need to be treated differently. There's a study that was published within the last year where patients with HER2 positive breast cancer receive their chemotherapy, get their surgery. Those with residual disease should then change their chemotherapy to another anti-HER2 treatment, and at least the initial disease-free survival appears to be quite good. So things are changing. Now, I'm going to tell you, one of the things when I read that was what's left behind. They haven't analyzed that yet. They are going to. Did we get rid of all the HER2 positive cells? Maybe we have hormone receptor positive cells. So it's complicated.
And it's a complicated thing all around. And that's, again, you said so many acronyms out there that I don't even know them all, and I feel like I know quite a few. But that's, I need to come next time and have my sheet of HER2 positive, negative, whichever the estrogen. And the reason I'm saying that is there's so many more ways of testing now that I get confused, and I can imagine what the general public gets confused at. So again, that's why if you can find a .org organization, and I'll say it right now, I usually say it at the end of the show, feel free to watch this again because it does go quickly, and what Dr. Rivera was talking about. So we're looking at kcostv.org. Just go to Watch and Programs. You can watch it again on Facebook. You can also watch it again at the El Paso County Medical Society website, which, again, it's so much information. On that note, now we have like 7 minutes left. Dr. Linderos.
She got 3, so I'm going to get 3.
No,
You gonna get 4?
I only need 30 seconds at the end of the day, so I'm good.
All right. Well, everybody's different. Everybody comes from a different background, and will have different risks. So I think the basic, the first risk assessment should be coming to the office and knowing, there's several models to determine the risk of a patient. That would trigger maybe a study, an exam, or continued surveillance. So there are multiple models. I'm not going to mention them here. But that should be as an initial, every patient that comes through the door with a breast issue should have their risk assessed in that way. Now, that also can trigger genetic testing, depending on depending on the family history, whether the patient had a biopsy or not,
Right.
whether she had a proliferative disorder in the past. So these are things that had to be considered. The other thing that I want to pass across is, if you have a family history, it behooves us to know about it.
Absolutely.
Try to investigate as far as you can who had breast cancer, maybe what type, or what kind of treatments they had. So your primary physician or your treating physician can actually
And age onset is a big deal, I understand,
absolutely,
correct?
absolutely.
Okay. So the younger, the more important it is. The younger that person, whoever it was that got cancer, that's
Absolutely,
very okay.
and that will make Dr. Rivera's job much easier in determining the pedigree and what set of genes need to be tested in that case.
Yeah, I mean, we recently saw a patient with, a mother died of pancreatic cancer. Patient developed breast cancer, and I believe she was in her 50s, early 50s. But because of the pancreatic cancer, testing was done, and she had an ATM mutation. So there are combinations, and we're just beginning to realize that. That's why BRCA is important. I mean,
Right.
it's the most common
Right.
of all the genes associated with breast cancer, but it's not the only one. And in this particular case, the question is, what should we do about, let's say, pancreatic screening? That's another whole lecture. But the point is that it's important that there are some cancers, daddy was a heavy smoker and died of lung cancer. Well, I'm not going to think about that one.
Right, right.
Or cervical cancer, which is related to HPV. That I'm not going to worry about. Ovarian, endometrial, these colon.
So that's where you have some genetic issues involved.
Absolutely,
Yeah. Okay.
absolutely.
Okay. Dr. Gupta, gadget lady,
Took one of your minutes.
what's the newest machine you bought? I'm just kidding. But gadget lady, what's new with the gadgets?
I think focused radiation,
Focused radiation.
image-guided
This is
radiation.
a beautiful subject, right?
Those are the two things that are the newest and are reducing toxicity and improving cure rate for many cancers. Before I used to treat just brain tumors with gamma knife. Now I treat lung cancers, a few pancreatic, some liver. So, and focused, targeted, so that the toxicity is very, very low. And the control rates are high. So that's what's new in the targeted world right now.
So translate that to me, so you're talking about a very focused beam. Is the beam smaller? Is the amount of radiation smaller? Maybe
No,
it's
the amount of
both?
radiation is actually higher per fraction.
Okay.
So it's not done as a 6-week, 7-week, the traditional conventional.
Right.
It's done in 3 days or 5 days.
And
But
they're done.
And they're done. And it is a very high dose, but it is very, very targeted.
Okay.
So the planning, the immobilization of the patient, and delivery all has to be very accurate and precise.
Right.
And there are multiple beams coming from different directions, so that's kind of neat.
See, that's the gadget lady.
But for this group, I
She spends
think
more money than.
But
that's
she
not
actually
true.
said that once.
Chemotherapy is pretty
it's
bad.
pretty
I
expensive.
know, but she just does spend a lot of money at the center.
I have some super quick questions here from the audience, and some we can answer super fast. I don't know why I keep saying super. So, recommendations for mammogram. I know for prostate cancer, African Americans do have a different screening and or occurrence rate.
Yeah.
For African American women, it's asking, are there recommendations any different for African American women than not? And I always think
For average risk African women.
No, not for
Okay.
average risk.
not for average risk.
But keep aware that African American women do tend to have the triple negatives and do tend to have the more aggressive cancers and actually have a worse prognosis even for stage. It's not a huge difference, but there's a small difference, and it's not socioeconomic.
So it's not a screening situation, it's just when they get a cancer. That's where it
Right.
gets,
Absolutely.
okay, tricky. Question here from the audience. Husband asking for his wife, can my wife receive a thermogram instead of a mammogram?
You answer that, Anu.
No. I know
No.
it's a loaded one, 'cause I remember this from a couple years ago.
Mammogram is the standard. I know some spas offer thermograms. Those are like thermal scans to look at the blood flow and heat in the breast. They can pick a few cancers because cancers are more vascular, but no way does it replace a mammogram.
Gotcha.
Yeah.
Makes sense. You answered this to a point earlier. 83-year-old female wants to know if there are mammograms available for older individuals. And I love what you said. If you think you're going to live for an extra 10 years,
Get your mammogram.
nicely said. Microvascular decompression. I don't know what that is. Any of the doctors on air able to perform this type of a procedure? I don't know
Is
what
that
that
you
is.
need a
I think that's
neurosurgeon.
what they're talking about.
Maybe, yeah, that's all the,
That's
so
a
my
neurosurgeon.
disclaimers, this is all I have,
No
so.
one in town is doing that.
Okay.
And you have to go to a specialty center. I know of a group in San Antonio, there's a group in Phoenix, and then MD Anderson's doing it. And it is difficult surgery. It requires a lot of experience, but it is being done. And we have seen one patient that I have that has helped. It doesn't completely get rid of the lymphedema, but it helps.
Okay.
Are they
Quickly describe
asking
to the
about
audience.
lymphedema?
They didn't say lymphedema, so they just
Oh,
had
what
the
did they-
microvascular so the question
maybe
is,
Could be
that's-
a trigeminal neuralgia patient who wants a microvascular decompression. I
Okay,
think
so we
that
don't know
just
what that
don't
means.
know
yeah,
what that
we don't know what
means.
that means. So look it up at find.org organization that you can do that with. I know it's almost silly, but it's not. We have about a minute left, so is there anything anybody wants to throw out really quick before we wrap up?
You know, you were talking about the websites. NCCN, which is National Cancer Comprehensive Network,
Excellent.
is an excellent website. There's a physician portion to it and a patient portion to it. They
So
can
NCNN.
NCCN,
Sorry.
National Cancer Comprehensive Network. And patients can go and set up their own login and go through the treatment guidelines. It's very nicely done.
Nice. Okay, so I'm going to repeat that again. NCCN. And it's nice if you can make it specific to you as well. Nicholas, I guess you're the one that you got to hang out the entire time. So Nicholas, I want to thank you so very much, and our audience thanks you very much because you were nice to everybody on the phone, right? So Texas Tech School of Medicine provides medical students for us that help us out the entire time. Again, this is Updates in Breast Cancer, and we will be back next year during this month. So maybe mark all the things that we talked about today, and it will be, again, very, very different. So American Cancer Society, if you are a telephone person, 1-800-ACS-2345, or for cancer, 1-800-4, and then the word cancer for the National Cancer Institute. I'm Catherine Berg, and you've been watching The El Paso Physician.